body be for the benefit of the mankind. Swami's essentially work was Karma Yoga in action. This is the hospital, this is something which I spoke yesterday as well. The real miracle was converting a desert, complete desert in a place of rock into Puttaparthi today what it is. It's taken a lot of unspoken, unpublicized kind of work for this. Swami's thoughts on medicine, very simple, and I think it's something that all of us as doctors, as students in cardiology and as doctors basically understand that each human has a right to his life. A very strong statement that Baba always said was, when you have disease which does not differentiate, why should medical facilities differentiate? That's something that should be free for all for the mankind. Again, what I said right up there at the top is written. So as we spoke in many of these things, we cannot put a commercial value on human life. And of course, Swami used to call this place as Bharat always. And with Chandrayaan 3 happening, we all know it's all made in India now. So essentially, hospital, which was a model hospital, Swami said, short of the numbers of these expenditure done, essentially. So we all believe it's just medicines for free, it's also allowed for free. Again, I thank my entire team, which has made this whole thing possible for us to have this thing right from the trust to every person who's helping us, to even the managers and the housekeeping staff, which has kept everything clean. So without any much ado, we'll again go for academics. Dr. Arun Vedava is presenting the next clinical case, and I request Asir, I request Ashmi ma'am and Patnaik sir to please moderate this issue.
Hereby presenting case of 20-year-old male patient named Shakti, coming from Krishnagiri district of Tamil Nadu. Informant is mother and patient himself and mother, and history is reliable. Coming to the presenting complaint, breathlessness on exertion for the past 5 years and associated with palpitation, which is also for the past 5 years. History of present illness. Since the history starts from the childhood, I would like to start from the childhood. So the 20-year-old male patient who was born out of by normal vaginal delivery with a birth weight of 3.2 kg with uneven postnatal history. He was diagnosed as congenital heart disease at 3 years of age when he was evaluated for upper respiratory infection. He was taken to a nearby doctor, and for following auscultation he was told to go for cardiac evaluation, and he was diagnosed as congenital heart disease. And he was evaluated from a patient care center. And at the 3 years of age, he was advised for an elective surgery, but the patient deferred the surgery and was lost for follow-up or was on irregular follow-up. At that time, the patient was completely asymptomatic. Cardiac-wise, there was no symptoms at that time, and he was going to school, and he was here with the normal peer group activities was normal for the patient. And he was taken to school, and there was no history of any hospitalization or recurrent respiratory infection in the past. Child presented currently with the history of breathlessness of dyspnea of exertion for the past 5 years. It was initially onset and gradually progressive. It was starting with the NYHA class 1, and over the past 4 to 5 years, it has progressed to NYHA class 3. Right, 22 years, sir.
22.
Yeah.
Last 5 years only
Symptoms, sir.
2 years. The heart disease was detected. Was it detected and told that there is a normal?
Yes.
But told about a normal event?
Yeah.
What was the consent shown by the doctor? That they asked for early surgery or you can wait for some time. What was the statement?
Because within 1 to 2 years, we have to do the surgery. It was not an emergency surgery was offered, but we was to do a surgery in the near time also.
This much of what are coming to your mind?
So from the history, for example, history, sir. Yeah.
At this point, what are coming to your mind?
So it's a basically congenital heart disease, probably assigned to congenital heart disease. There was no any physical operation was not during that period, and which has progressed over a time and presented currently. So it could be one of the possibilities can be a moderate size subpulmonary VSD with mild AR at that point.
Why you are thinking of subpulmonary of all the entities?
No, currently palpitation is also there. Yes. No, the thing was this palpitation also was is currently there. That's why it was. Yes.
So the moment you tell about chief complaints,
Yeah.
what are the things which are in your mind you have felt? After discussion of the history, again you have to analyze.
Yes. Yeah. Maybe progress to do air and progress currently making 96%. Or it can be a large Austrian secondary, large ASD with associated with or a partial very canal defect with a at that time area. Now has progressed to severe area currently.
That's so important.
Yeah.
We as somebody diagnosing a murmur,
Yeah.
we should also find out who has diagnosed. Sometimes a less trained doctor may diagnose even an innocent murmur as heart disease. Okay, that's a possibility. It happens. So,
Yeah, it was
being a
cardiologist.
qualified.
Yeah.
So can you tell something about innocent murmurs? In years old, what are the important innocent murmurs?
Innocent murmurs can be in the especially in the childhood there can be innocent murmurs because there will not be any cardiac lesion associated with it. Usually it will be having a 2/6 murmur which is having some kind of musical tone kind of.
Can you give some examples? Sir? Some examples.
Anemia can be the anemia.
Anemia may cause.
It can be thyroid. Anemia is one of the most common possibilities. That can be.
Innocent and functional murmurs.
Yeah. Stills murmur.
What is the innocent murmur and functional murmur?
Functional murmur is stills anemia. Anemia is functional murmur.
People innocent murmur. Give an example of innocent murmur. Stills murmur.
Stills murmur.
Yeah, right. For us, there are some at least 5 situations where innocent murmur is. For example, venous one.
Stills murmur.
Give an example of functional murmur.
Functional murmur because of the one of the possibility anemia, sir.
Functional murmur. To get engine in the face in BSc.
Yes, because it's a large flow.
But innocent murmur, functional murmur.
Flow murmur, that is flow murmur.
So that's functional or pathological?
That is functional murmur. Flow murmur, it's in the left right region across the mitral side. Flow murmur is a functional murmur. The anemia murmur, which is happening to hypothalamic septum, is also a flow functional murmur.
So it was diagnosed by a cardiologist and step only. You could not know that time.
Echo was diagnosed.
You could step up. You mentioned that
Yeah, it was initially treated by pediatrician and was referred for further evaluation and was evaluated by the cardiologist and tertiary care center and was advised for surgery. But the patient was felt they were lost for
Any other
4.
important history?
He is also having past 4 years recurrent palpitation history also present, sir. This is also associated with the exertion and it comes from with that it usually starts around 10 to 15 minutes. That is also for the past 4 years is present, sir. Exertional palpitation as well.
Recurrent palpitation.
Difference between recurrent palpitations and occasional palpitations.
Yeah, okay. Exertional palpitation generally because of the body mechanical condition, sir. Whereas the paroxysmal palpitation can be because of the any arrhythmia kind of event, sir. Especially,
Basically, you have to differentiate between arrhythmic type of palpitations and remote and two types of. So in this case, what do you think? It
more of
is
exertional
exertion. So related to the remote and problem.
Arrhythmic palpitation cannot be adjustment. Arrhythmic palpitation cannot be adjustment.
Can exertional palpitations be arrhythmic in origin?
Can be, sir.
Which country will get adjustment arrhythmic palpitation? Yeah, then what are the conditions? application.
Did you tell us about the onset of palpitations?
Yes, for the past patient direct palpitation for the past 5 years, sir, 4 years. Which was
No, the onset of each episode.
Yeah. Each episode usually happens in an exertion and it usually comes down, sir.
Is there any postural variation of the pulse? Is it important? Suppose the patient tells left lateral position, I get more palpitations. If I sit up, it's not there. Sometimes volume overloaded conditions, when the curve to the left, and then
We appreciate once.
So we heard of it is hemodynamically volume condition, not dynamical. See, on existence of the output tract cardia, output tract diagonals can be considered by exertion. QT interval, long QT, no, the answer is and cardiomyopathy, there we see, they are all exertion intervals. And also know that there is a sympathetic induced articulation, hyper-induced articulation. No, that is different. So on exertion, articulation can be induced. On sleeping means it is vagal induced, vagal mediated.
There is no history of any recurrent LRK in the past. There is no history of fluid discretion or no history of fluid discoloration. There is no history of any chest pain or there is no history of any syncope was noted by the patient, and there is no history of any edema or abdominal distension was noted.
So there is no important history besides.
Yes.
So tell us what for diagnosis from the history.
So basically, summarizing the history, a 22-year-old male patient was initially detected to have CHD at 3 years of age. It was told for elective surgery. It was lost for follow-up and presenting with dyspnea of exertion and palpitation for the past 5 years.
Yeah, that is the summary of the history. Yes. And then what diagnosis you want?
Coming to the differential diagnosis, first of all, it's a I would like to think of a congenital heart disease because it was detected by 3 years of age. Probably acyanotic congenital heart disease because there is no history of any sign of this was noted.
Fine, acyanotic heart disease.
Yes. So first one, so already mentioned, it could be at that time it could be a moderate subpulmonary PhD which with a mild air.
Why do you only be to
Yes.
And that differential diagnosis.
Yeah.
Is some aorta application.
Yes.
No.
PhD, some PhD.
Because now it's
It's a little more broad. Some left to right shunt without significant shunt. Moderate shunt.
Yes.
Left to right. It may be at any level.
So can
It
be
can be MBA, it can be PhD, it can be AP window. All these things, the effective shunt is less than the symptomatic.
What can be also already mentioned can be a case of large ASD with mild. It can be a vaccine anomaly, sir.
Left to right shunts,
Yes.
yes. Significant shunt.
Yes.
So why left reaction? Why not? Why left reaction? What is this suggests to left reaction?
One is that there is no cyanosis, sir.
Fine. The acyanotic congenital is the main reason, no?
Yes. So one of the other most common congenital heart
At
disease.
3 years of age, arterial surgery,
At 3 years of
non
age,
standard.
at 3 years of age, 3 to 4 years old, somebody addressing for surgery for left right shunt.
No left reaction. No left reaction.
Yeah.
What arterial surgery?
It can be any aortic or abnormality, sir. Like there can be subaortic stenosis with a AR. No just progress, sir. With a or it can be bicuspid aortic valve, which is already now progressed to a severe
How
AR.
do you can balloon dilate? Why it was surgery?
If it is aortic valve,
Okay, so what is
but if it is subaortic, it can be a surgical.
Is that the concern? No.
Sir?
clinical conditions of the surgery.
No, better you think of different types of groups.
Yes.
One is country.
Yes.
Second is valvular heart disease. But it's not significant registration or significant stenosis. Because the doctor told no hurry, but sometime it has to be. That was the wording. And also patient is not symptomatic. That signifies that either the stenosis is very significant, critical, or the registration is very significant, maybe moderate, or it may be combined events. Valvular patient as well as shunt together.
Yes.
What other groups you can think of?
You can also think of the Avcd anomaly, sir. Could be Avcd anomaly. Currently, person with dyspnea exertion. Sir, currently person with dyspnea exertion. Because there can be arrhythmia can be there, sir, and also there can be.
What pathology you are asking? What pathology in abstinence?
This is a shunt lesion or is a valvular lesion?
Valvular.
Registration may be here.
What is supraorbital stenosis? So many conditions can be supraorbital stenosis. Huh?
Or it can be an anomaly of the mitral valve, sir.
What anomaly?
It can be any congenital anomaly of the mitral valve, sir, because at 3 years.
What condition? What is congenital anomaly?
Either passive mitral valve. Now you might have voice with moderate severe MR, sir, or it can be like any mitral collapse which has progressed currently, or it can be double orifice aortic mitral valve, or it's a hamo type of mitral valve. This all can take the process with dyspnea exertion and also with some kind of palpitation. Generally, that's yeah, that's it. And
Just use the mic.
Important for patients. All the things you don't know.
Avcd anomalies. Or it can be a heterotaxic common partial Avcd with Avcd canonical, or any kind of heterotaxic syndrome, where it can be anomaly of the
PDA and ASD can refer this. PDA
this kind of. ASD is a large ASD because of the right enlargement possibility, sir.
Any type of facility is possible with ASD.
ASD, sir.
But it is not arrhythmic practice. It is it's non-arrhythmic practice. Non-arrhythmic practice. So PDA and ASD, ASD matter, prolapse matter disease, apply matter valve, all partial ignorant defect, person primary ASD matter here. What question is there? Presence.
The examination, vitals, because heart rate is 84 beats per minute, regular rhythm, normal volume and character of the vessel wall, and there is quad paper pulsar well and equally fed, and there is the radio femoral delay. BP is 1 time per 64 millimeters of mercury in all the 4 wings. 1 time and the lower wing BP was 1.4 millimeters of mercury. Saturation is 90% on all the 4 wings, sir. And he was affected at the time of examination. Respiratory rate was 24 per minute, is abdominal thoracic, and JVP was elevated around 10 centimeter above the sternal angle with a prominent V wave. Anthropometry, his weight is 44 kilogram and height is 158 centimeter with a BMI of 17.6.
Prominent view.
Wave is present.
But the performance was immediate.
What was the distance?
Normal.
Prominent view, there must be the white
Five
side.
points.
Prominent view, so why must you wait, sir? Why isn't it what? Why isn't it?
Very glass.
Dots.
You because of ventricular contraction. Ventricular contraction is what was that ventricular contraction? You tell what is the age due to atrial contraction. After then what was it for? You know what name of the descent? X has two parts. Why do what? And my question why because what?
Atrial is because of the atrial contraction. X descent is due to atrial relaxation. Atrial relaxation is X descent. And X prime is because of the further relaxation of
No.
Yes.
Which is systolic, which is diastolic.
X descent is systolic, no?
It's prime descent. So it's X and X prime descent.
Yeah.
Y descent?
It's diastolic.
No, that's what I was asking. In diastolic comes, what is the mechanism? V wave is systolic or diastolic?
V wave is systolic.
Systolic. You are systolic. You are systolic. You are systolic. Systolic, but you are systolic. You are diastolic, no?
Yeah, because of the tricycle goes up and there is a atrial filling happens. And can be formed slowly?
Y descent is diastolic.
Diastolic.
If you have to time the Y wave, the JVP, it will come after the second or
Second
third
order.
base. You have to
Yes.
auscultate at the base and look at the base. That's how you differentiate X prime from Y descent.
Which concern why descent absent or very small why descent?
So it's really actually target
And slow why descent?
Stenosis. Stenosis.
Slow why descent?
Tricuspid stenosis.
Yes, sir.
Yes. Any other question? Any other question?
Yes, in army failure, army diastolic dysfunction. Army dysfunction.
Right to this one. This one's going to be right to this one.
Dominant Y descent and palpitations. So what condition comes to your mind? Dominant Y descent and palpitations in the history. You already applied that.
Delay will be probably because that's, yeah.
Talking so much about palpitations. Did you look at Y descent or not? I was asking.
Coming to head examination, current phase is just normal, oral cavity normal, there is no caries tube, and there is no pallor, there is no cyanosis, clubbing, for lymphadenopathy. Upper and lower limb is normal, and coming to cardiovascular examination, instruction and palpation together. Avcd is visible in the fifth right intercostal space in the midclavicular line. Right is the right intercostal space. Sixth right intercostal space in the midclavicular line, which is a LV type of apex and it's a hyperdynamic type of apex. And there is a visible precordial bulge is present on the right side, sir. And there is a right parasternal heel is appreciated, A to right parasternal heel, and there is no palpable P2. Right, yeah.
And your apex is hyperdynamic every type.
Yes.
Hyperdynamic.
Yeah, hyperdynamic. And there is no other source of palpable. And coming to the percussion, and right, what was not corresponds to apex, that's what was.
Let us see what for the percussion. So before putting step out, what is your understanding of the case?
It's a Dextro Cardia, sir. It's a LV type of apex.
Okay.
And the features of pulmonary artery hypertension.
Due to?
Due to some volume over.
Sorry, then you told there is no sound palpable. No, people not second sound not palpable.
Yeah.
That will peacefully there no.
So can you? Sorry, now it is Dextro. So the JVP you saw on the right side or the left side?
Right side.
Solid.
Dextro cardia, JP right side possible. So if JP right side you can see properly, what possible the situs?
Solid, sir. And the auscultation. This one is normal. Examination planning. So we are able to appreciate Dextro cardiac heart, sir.
It's no cyanosis.
Appreciation is 90%, sir.
These cyanosis are not clinical cyanosis.
In the all of them.
These are system pieces in there. Okay, fine. Then the sample advantages. Then what else?
Inflammation order performance.
Only what is the storage mentioned and the dating certificate. Normally, and the previous is required 40%, and that's it.
My use
Dextro cardiac heart is a recorded bulb with a right parasternal tube. And then hyperdynamic type of effects.
Put the same ventricle, one ventricle, single ventricle, possible.
It can be so. It can be a single ventricle for LV morphology is a possibility.
The same ventricle, total getting a parasternal right
It
parasternal.
can be possible.
Possible.
Because understanding about dextro position and dextro type.
Dextro position means the heart is moved to the right side, with the apex is pointing towards the left side of the patient. When the dextro cardia, the axis of the heart is going towards the right side. If you are drawing a line from the dextro side, it will be going towards the right side. Where the dextro position, heart will be pushed here and towards the left side.
Okay. So, LV hyperdynamic?
LV is hyperdynamic.
So, is there any general concern supporting your LV hyperdynamic system? Is there any evidence of out income not there?
Yes.
And then,
There is a auscultation wise. Coming to auscultation wise. Auscultation wise.
what could the cause of here will be hyperdynamic? What could be the possible cause?
It could be because of the MR compound, sir. There is a I don't know explain about the oscillation findings.
Are you getting an LV history after?
No, sir, I couldn't get it in any way. And he was filling in the writing
Partial leak is early systolic or late systolic? Partial leak is early systolic or late systolic? Which consume the late systolic partial leak?
Elevation.
Okay.
This is very
Late. That means what?
no, this is
Early.
very
So it is right ventricle impulse rather than LV impulse.
yes.
Fine.
Other one side is the tympanic compass appreciation on the left side of the patient, sir. So the side is solid.
Fine.
In the auscultation, S1 is normal, S2, A2 compound is normal here. There is a loud P2 with a wide split with a loud P2 is appreciated, sir. And there is a pansystolic marker,
Why is it not enough?
wide fixed split, sir.
Why it is?
And there is a 3/6 high pitch soft flowing pansystolic murmur is appreciated at the apex of the heart in the right lateral position, which is also somewhat predicted towards the base of the heart. No other additional sounds were appreciated. Coming to the other system examination, abdomen per abdomen so there was no hepatosplenomegaly and liver is there is no hepatomegaly and tympanic node of the doctor's stomach is separated on the left side. Respiratory system examination was within normal limits and other system CNS is also within normal limits.
You got a single murmur.
Sir?
Single murmur.
Yes, single one.
So you synthesize now.
So coming to the diagnosis, could be probably situs-soltus.
Just a little bit.
So examination wise, examination wise, Dextro Cardia with a hyperdynamic LV type of aspects.
To summarize cardiac findings, like pulse, JVP, blood pressure, then presence or absence of cyanosis and clotting. 5 points you have to tell, then you are asked to summarize. First, then you go to the cardiac.
So cardiac vital examination pulse is 84 beats per minute with a normal tendency with a BP of 104 by 64 millimeters of mercury with a significant saturation of SpO2 of 90% with a prominent V wave in the JV which is elevated with a prominent V wave and with no features of clubbing or lymphadenopathy. With a cardiovascular system examination, there's a dextrocardia with a LV type of hyperdynamic apex, which is in the fifth intercostal space, fifth right intercostal space, and with a gate to right parasternal view, with a loud P2, which is a second taxonomy which is fixed with a loud P2, twice it's a split, with a pansystolic murmur of 3/6 head at the apex. Situs-soltus dextrocardia, congenital heart disease with a large ostium priming ASD or common atrium with moderate mitral regurgitation, with moderate pulmonary arterial hypertension in sinus rhythm with no features of congestive cardiac failure and no features of infective endocarditis.
Second, some other type of PhD.
Only point was
You can at best tell the read like a switch pattern. They are not full of your ASD.
only thing which is saturation was around borderline 90%.
Whatever it
No, can AC patient no, the question taken on AC can have saturate 90%.
Possible.
Oh,
If the initiation mode is not directing the blood towards the left atrium, it's a possible.
why did Austin Brahman then you?
So what are the one down is there cyanotic ASDs. So what are those cyanotic ASDs? One you told selective streaming of IVC like
There can be untrue coronary sinus draining the blood to the left atrium, sir.
Anything?
What can be person LFC draining the blood to the left atrium?
not EAPs.
What? DAPS is
Cyanotic ASD.
So then how come this you are getting it tall EOA with Austin Brahman with MR normal apex, transformer apex, Austin leak, permanent EOA? How to explain this?
maybe the MRP. It's a large AS. So we are considered
Only large ASD, later son, how come get patient got 90 saturation now?
Usually when you get 90 saturation, somebody is good fit to make the patient go on the treatment and look for clinical cyanosis. So that makes your life easier. You can say that there is cyanosis, but while at rest he has only 9 desaturation. And if you do exercise, cyanosis could be appreciated. Okay. It's a better way of defending the
What is the parasternal heat due to?
Breakthrough.
No, what is it due to?
Due to. He's already put on the ocean prime also. You get heavy.
Are you volume over?
Here.
Yes.
You see, remember, in case of the HT side, Balkan side like the HT to MR, you won't get LV, you get RV. HT MR, LV won't relax. RV will not. RV won't affect.
How will the MR affect the hemodynamics of ASD?
Yeah. How many please? No? How many please?
No outflow moment.
There's no outcome, how can you think about the HT? That's so much cardiomyopathy. That is the next question, of course. That's what I'm asking you. Please. I don't know what to do. I don't know.
Dextro number product is the RJC.
The JFP is very high.
That is you or you? First round is split or first round is single?
Single, sir.
Second round is clear in a white shirt.
Yes.
You do the resistance because the resistance is so nice and so what are the bond against resistance?
Every time.
What is most important here?
Absence, classical technical findings are noise sadness may be there. Particle sounds, splits first order sound.
And people
Second order sound.
say no please.
Usually JVP is not available.
And people won't love. And people won't get.
Both are mimics actually many times on surgical table they get the surprise. This entire industry what they just told you. And I got extension.
One small question about DVT. It is very much elevated after the end of graduate. How do you measure the DVT?
No, if you do this, you won't get it.
No, this is a separate question. This is a separate question, not related to that. This is a DVT is elevated, that is DVT. If markedly elevated, how do you measure the DVT? You can't see the upper upright position also is not coming down. So you use a method called Gartner's method. Identify a range and then lift it up such that it disappears. And then measure the vertical distance where it disappears to the circle axis. You get it.
So happening average every type of average in a passive phenomenon type is prominent. So if you have
It can get clear normal. Yeah. Yeah. Yes. 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 I tried, but I was not able to put it.
Use the mic.
How is, you see that it's increasing with inspiration.
They are normal there, but not increasing in inspiration, for sure. Here is there, but normal not increasing in inspiration. Are we dysfunctional?
Because there is a Dextro version in this patient. So Dextro Cardia.
Dextro Cardia.
Dextro Cardia.
Introduction to right.
Usually in
Otherwise, you can think of cardiac transposition, that side.
Could you please write transposition with the HPRD malformation?
Yes.
So discuss with this, but how to explain that 90% success, how to explain? That can explain. On this basis,
significant sections you can put in the last. Maybe you can put that.
but you can't explain that research.
When the extracardiac case comes, it's not only confusing to the candidate but to the examiners also. So we can have the benefit of the confusion. When you have to depend on the investigations.
Any differential?
Any difference, sir? So we already discussed difference, sir.
Especially when there is extracardiac, you have to look for any other signs of across axis increase. If it is possible. Basically, sometimes it's not possible. You have to depend on that. Also, mentioned common agent. What in clinical examination suggests common agent?
Saturation is one possible difference. Saturation 90%, and there is a
So whatever you say, there's things for a doctor.
yeah,
The evidence is not there.
and there is a recorded purchase there.
No, there is no argument.
Yeah, yes, some.
As for your credits, there is no argument.
In heterotaxy, how do you remember whether the screen is polysplenia or asplenia? How do you remember it? If it is bilateral left side because or bilateral right side because in which there will be no screen, in which there will be no screen. But how do you remember? See, the way you remember it, screen is always the left side. So when everything is left sided, there is no screen. When everything is right sided, there is no screen. That's how it.
Receptor defect is considered here as a clinical diagnosis. Okay? Okay, go to the investigation.
This one will be considered. This is the
Yeah.
Secondary ECG, normal standard patient, patient is
This is the one on the left.
Yes, it's a dual ECG normal standardization, showing that there is no there is a irregular tachycardia, there is no tears is visualized and tears, no tears are visualized, and there is a axis is axis around plus 180 degree. AVF is equibasic, sir, and the lead one is negative.
AVH is not equivalent.
again, making it to still there. So we
This is AVS. Okay. Oh, this is AVS. Axis is around plus 210 degree. It's the extreme north-west axis with the
Either this way 210 or this way minus 1.
yeah. And there is we are not let's say figures are not there. It's like a probably AFD controlment of the range. And there is no RWave progression is seen. There is a
Yes.
yeah. There is no RWave progression is appreciated, sir. RWave progression is not there. Only S-waves regression is there. So the features of the Dextro Cardia, sir.
Actually, in these conditions, you can have AF, but you can have negative or persistent atrial expansion or atrial inexcitability. So then you can have some sort of junction to the present. So this is irregularity is there.
This is the correct.
So there is a septal activity here.
Fluids are frequencies fluids are present, sir.
Yeah, we have put it to the right. Is the correct?
But the limb length is still the same. Limb length has not been inverted because the axis is still pointing. Okay, interpret the chest beats.
In the chest is kept on the right side for a Dextro Cardia. There is a non-RWave progression is seen, sir. And there is a predominant LV forces are appreciated, sir. There is no features of RBS. And there is a LV forces are appreciated. There is no features of sir. Can be any type, sir, but the axis will be that axis in there. Not cluster.
ASD was a strong consideration for you. Now does this ECG support it or is it against it?
It's against it.
Huh?
Against.
Why?
Because there is no RF force, there is no right ventricular force are not applied. There is no RS R dash pattern is not seen in the V1, sir. Which means the ASD will be RS R dash and pattern can be.
Actually, Dextro is difficult to rule out the and strongly ruling out rule out. Because the regular ones they are not very sure. The effect is coming from the very automatic approach. Rule out the ECG abnormalities and try to do it possible.
No, but if you look at the septal vector and the thing, it looks as if the RB is anterior and the LV is relatively posterior.
The major ventricle is anterior, the ECG is complex.
Because the D2 is down means posterior ventricle, and D6 is the posterior ventricle. LV.
Hemodynamics looks like there is a every volume overload can be appreciated, sir, from the ECG. With features of atrial fibrillation.
Okay.
Fibrillations.
Okay, then.
TH is not there, sir.
RB force not there.
Not there.
So what if once RB force not there, but we are getting so much cardiomegaly, RB force not there. So what are the possibilities?
It can be a single ventricle disorder, probably, sir. Because there, so single ventricular error of any morphology in this can be a possibility.
Reference? What is against reference here?
There is no splintering of QRS also.
No splintered error.
And generally, the IPD we cannot comment, but still the figures will be tall. Figures will be cannot be.
So this young age articulation there. No, young person young.
Yeah.
Articulation there. And this sort of normal getting. So what are the possibilities? And the mother had this.
It can be a partial ABCD which is MR, sir, not possibility. Small. The MR.
We are still arguing not getting no arguing.
Small as. Basically, that's called a forward condition we have to suspect, sir, here from the ECG wise. And there is a significant, with some form of which are also having arrhythmia features.
Practice also.
Sir,
Practice.
like a splenotropia? Yes, sir, single one.
No cyanosis.
But there is no cyanosis for the patient. And cyanosis because significant cyanosis.
Second sound voice to be loud also.
Yes.
So second voice split, either because of some pre-traction or patient having RE responsive case. So pre-traction sound goes for the second sound splits. So taking into account the possibility of RE body not there.
Sometimes target transmission also you can have here. This is
But different malformation possible.
But septal vectors are okay. Without septal inversion, you won't get that.
There could be associated VC of the VG malformation.
Yeah, it can be there, sir.
Because he can have the
We cannot even
the budget VG is also common. Different malformation also there could be. But there is no PA.
Yes.
And VC
That's
and having different malformation of
Single unit and common use after defect. That is which can be put anywhere. Whenever there is a confusion, it should be put there.
Dextro Cardia with a cardio CT ratio of around 65%. This is the every type of complex. And cardiac in the pulmonary vascularity appears to be increased, and there is pulmonary vascularity appears to be increased. More looks like arterial. There is no. It's like arterial, sir. There is no. They are not able to because of pulmonary venous hypertension, like separarization of veins.
There's no person there.
How many are there?
Guiding, what is the normal? How much is normal?
Around 45, 60.
Actually, and when say the active-ventricular relations,
Sir?
active-ventricular and ventricular relations connected, we are going with
This is situs alters, sir. The cardiac situs also will go with the abdominal situs. So the atrioventricular connection, situs alters.
See, visceral situs is normal. Likely that atrial situs coincides.
Yes.
So right atrium is also right.
Yes.
So now you can have
Atrioventricular.
Atrioventricular situs comes there.
more like
This looks like concordant only, sir.
How do you know?
There is no L posterior aorta is not visualized here. If it is a rear discordance, we will be seeing a L post aorta, sir, like CTGA. But here with the aorta,
Sorry, 1 minute. We are saying that the atrial situs is normal.
Yeah. First, because of the
it goes in
Right.
you see that no, this is right from the straight, left from the left side is normal. So our question is active-ventricular relation. So when they wrong or doesn't matter. So the LEs are attached. Postoperative definitely.
affected from the left ventricle.
And right hand and right side.
Yes. So if discordance is possible, discordance is a possibility. Yes.
See, actually, nobody will know the exact thing. You will only look at the discussion. How do you approach it? What is the challenge?
This point was discussed yesterday and it is pointed out even more impressively than what we saw yesterday. That the lower diaphragm is on the side of the apex. It has nothing to do with the liver or the stomach. In this X-ray, it's brought out very, very clearly, and also the bronchial pattern.
Bronchial anatomy is very important. The echo, of course, IVC. Suprahepatic IVC is more important. This is
There is some side surface and active-ventricular and ventricular disturbance proven. And there is some increasing from the blood flow. And imaging.
And then it's a percentage like of the aorta. Aorta is on the right hand, IVC is on the left hand. Aorta is on the left hand, IVC is on the right hand. This is a apical force. Supposed view with a supposed coronal view showing a quarter posterior so far. There is a large ostium we are able to see in this view they are able to see a large ostium primum ASD with the
you go what is known by segmental analysis.
Yes.
You have to talk about the visceral side. Then you talk about two atria, two ventricle, two greater arteries are not there. That you have to tell.
Yes.
Then you have to talk about whether right atrium is on the right side, left atrium is on the left side, like that.
So we just IVC is ready to which atrium we have to see.
So your wording should be first about the visceral side. And about the atrial hernia, everything is hernia, gate hernia. Then you will talk about whether the right side and morphologically right ventricle is on the right side or not, right atrium is on the right side or not. Those things, then its concordance are discussed. In that way, you have to take then additional findings.
Then able to see a IDC which is guiding to the this is guiding the right atrium. So on the right side we have the right atrium, and there is a complete AV canal defect, sir. Showing a so there is a from here I can say there is a AD convergence is there, sir.
There is some second there. There must be friends. Is it there? So there must be HCV. Two is there. And the LA is connected to hypertrophic and RA is right ventricle.
Maybe it is called as
And two large HCV. Two big holes in that.
Important to describe the atrium as systemic venous atrium, pulmonary venous atrium. Within your shape. Okay, not good. But those terms you can use it.
so the right side of atrium is connected to the left ventricle, and the other left atrium is the pulmonary correspond to the right atrium, right ventricle, sir, which is a trilocated.
This idea and this so it's abdominal disturbance there and two large and to there is collapsing.
Then others, somewhat moderate, both left and right.
And those were the mental applications, what I think that will not. And presence will pH because there is low flow after this. There is low flow that has some fun.
But an RS of 80s.
80. That's why they are not getting flow in the IOT.
This is corresponding what I execute the border level, so it may normally related to data at least. What is on the right hand post here? Pulmonary artery on the right hand angle, left hand
Okay, for relationship, mental application important.
Sir.
Mental application.
Yeah.
Any discordance with BA component.
Very
Actually, that's why we did an MRI. This was done twice, one at Narayana Vidyalaya and both.
So that is just a transfer physiology.
Yes. We did it before. BA components. Thought it was was actually wrong. He repeated the MRI here, said the same thing. He will discard it.
Yes, whatever you do, so it document it, and I said, because this seems like either DSD percentage, large either DSD. Could be good, we are not in the MR area, because we have MR is the control. DSD cannot cause this marker, because they are here. We are able to see the one data coming from the LT, which is looks like iota answer. It should say DA convergence visualized here.
Okay, you do your final echo diagram. Okay, I think we attempted well and systematically. That's what is needed in exams. As I told both the candidate and the examiners are liable to be equally confused. But at each step we should use a reduction. Because of this may be possible. Because of this is more likely. So that should go on, and we'll be lucky to get a such case because you will usually pass out. They won't fail because there is nothing called gross mistake.
Actually, pass out in both the ways. Pass out is the exam was.
See, coming to my FNS question, how do you do a reporting?
Sir, I asked this yesterday, sorry case. How do you do a reporting casing in this patient? Sir,
Plain electrogram, how do you do it in the direct transfer?
Like Ramakrishna, do you have any comments on this case?
Possibly you need to go chance to depend on your pressure from the police. I'm not very certain that it's a large case. You think it's not too large.
Actually, in the MRI, sir, they are reported as a transitional type indicator with
No VSD type.
small VSDs. They have written as
After issue that, basically it's not a large VSD. Because I think you have to.
will work.
So go retrograde.
Which against the non-permitted cause. And right to pick up the not necessarily the short. Here you can have even duplicated areas. You can have double areas.
I thank all the faculty for this, and especially a big thanks to Arun for presenting this case. I told you they are doing a very difficult case. And Dr. Govind both. I request Rashmi ma'am to just give him a small minute on our behalf. Thank you so much, Arun, because these cases get everybody reached by your decision. Thank you. Thank you, ma'am. Thank you, sir.